Welcome to the Cardio Conversations. Today we're going to go into the chapter covering cardiology, which is one of my favorite topics. I've always found cardiology fascinating, and I was fortunate enough to work in a field called clinical engineering, where I had the opportunity to see firsthand how technology, how medical devices play a crucial role in cardiovascular care. So from things like pacemakers to heart monitors, these advancements in the field, they are truly incredible. So that gave me experience and a deep appreciation for the complexity and the importance of heart health. And I hope you find this chapter as interesting as I do. So let's go ahead and get started. Where we're starting is with word parts, like we always do, because understanding the language of cardiology is key to mastering this topic. And just a quick note, the terms that you're going to learn here are not all of the combining forms that you're going to encounter, but these are the most important ones. You'll find more in the book. You'll find more online as well. So just what I want you to do is get comfortable with these word parts, get comfortable with the prefixes, suffixes as they appear in the chapter. And another note, if you're still struggling by this point, remember it's never too late to sharpen your understanding. Just take time to focus on these building blocks because you'll see them again and again and again throughout the course and throughout your career. Okay, let's continue on to Cardio Conversations, where we are going to start the first part of cardiology word parts, which is focusing on combining forms. So we need to understand these in order to help you break down complex medical terms and strengthen your cardiology vocabulary. So we're going to do these in alphabetical order, just like we normally do. So cardiology combining forms, the first one is athero, which is a fatty deposit or plaque. And this refers to fatty plaques that build up inside blood vessels. They contribute to conditions like atherosclerosis, which is hardening and narrowing of these passages or vessels due to plaque accumulation. The next one is atrio, such as an atrium, the upper chambers of the heart. This comes from the Latin word for inner courtyard, which is why modern buildings still have atriums or atria. Right, so in the heart, the atria are the upper chambers that receive blood before passing it to the lower chambers, which are called the ventricles. The next term on our slide here is cardio, and that refers to heart. And this is a familiar one to most of you. Cardio refers to anything related to the heart. So examples are cardiology, which is the study of the heart, cardiomegaly, which is an enlarged heart. Most of you, if you exercise, you might do cardio, right, which is referred to strengthening your heart. The next term is constricto, and this is to tighten or narrow. So think of vasoconstriction, where blood vessels become narrower, and that also increases blood pressure. The next one on the list is corono, and this is encircling like a crown. So the term coronary arteries, this comes from the root because they encircle the heart like a crown, providing it with oxygen-rich blood. I've always looked at the coronary arteries and I thought they don't really look like a crown, what you would think a royalty crown should look like, but it's because they encircle the heart like a crown. And we'll discuss the coronary circulation in more detail later in this lecture. The last word on this slide is dilato, and this refers to widen or to loosen something. So you've probably heard of pupil dilation, for example. You're at the eye doctor and they give you some drops and they dilate your eyes. That just means that they're widening the pupil. For this chapter, we can look at in cardiology, we can look at vasodilation, and that refers to blood vessels widening. And again, that actually lowers blood pressure and improves circulation. So recapping what we talked about in this slide, athero means fatty deposit or plaque. Atrio refers to like atrium, or in this case, upper chambers of the heart. Cardio refers to the heart. Constricto, to tighten or to narrow. Corono, to encircle like a crown. And dilato, which is to widen or to loosen. Okay, and that's our first slide here on word parts. Okay, let's continue with cardiology combining forms, and this next one is ISCO, which refers to a blockage or restriction. So this refers to like a blockage or reduction in blood flow. Our example would be something like ischemia, And that's a condition where a lack of blood supply, and it's usually due to like a clot or a narrowed artery, where that lack of blood supply reduces oxygen to tissues. The next one is sclero, and that just refers to hardening. You may remember this from neurology. So when we discuss multiple sclerosis, MS, in cardiology, it's referred to as hardening of blood vessels. So this could be arteriosclerosis, hardening of arteries. The next term is septo, divider or partition, right? So a septum means a wall or partition that separates two areas. So an example would be the cardiac septum. That divides the heart into the right and left sides. You have a nasal septum. This separates the two nostrils. Right, the next term here is steno, and that means narrowing or constriction. So this indicates a narrowing of a structure, and it's often used in context of blood vessels. So for example, coronary stenosis, which is a narrowing of coronary arteries. And this can reduce blood flow, and it can lead to chest pain or even heart attacks. The next term here is valvulo, which just refers to valve. I'm thinking of a oil for an engine that is supposed to, sorry, every time I go off these little sidetracks, it throws me off. I'm thinking of an oil that we use for engines, and its name is Valvoline. Sorry, I don't know. Anyway, let's keep going. I'll try to not to get too sidetracked though. Okay, so valvulo, right, refers to valve. And in this case, obviously, we're talking about heart valves, and heart valves are used to regulate blood flow direction. And a good example of the term valvular would be valvulopathy, and that's just any disease that's affecting heart valves. And the last term here is ventriculo, right? It refers to ventricles, and in this case we're dealing with lower heart chambers. There's more ventricles in the body than in the heart, but since this is the heart chapter, they are the lower heart chambers, is what we're referring to. And specifically it refers to the lower chambers of the heart, which pump blood to the lungs, and that's done through the right ventricle, and then it pumps blood to the rest of the body, which is done through the left ventricle. All right, so recapping what we covered on this slide, ischio refers to block or restriction, like ischemia. Sclero refers to hardening, like arteriosclerosis. Septo means dividing or partitioning, like the cardiac septum. Steno refers to narrowing or constriction, like stenosis. Valvulo refers to valve, and our term was valvulopathy. Ventriculo refers to ventricles, like the lower heart chambers. Thank you very much, and let's see you in the next slide. All right, continuing on with cardio conversations. In this slide, we're covering some essential cardiovascular combining forms, and I want you to pay extra close attention to these because they can be tricky. Many students mix them up, but don't worry, I'm here to save you that headache. So let's break them down carefully, deliberately, so you can master them with confidence. And the first one is angio. There's another word that's related to that is vaso, and then vasculo. All of these just mean vessel, right? They're non-specific, but they just mean vessel. In this case, for this chapter, in context, when we say angio, we'll be specifically talking about blood vessels. All three combining forms mean vessel. They don't actually specify whether it's an artery or a vein. A blood vessel is just a blood vessel in this chapter. So in cardiology, if I say blood vessel, that could mean any vessel that moves blood around, arteries, veins, or capillaries. Right? Some examples of terms with these: angio, vaso, and vasculo. Angioplasty, right? That just means surgical repair of a blood vessel. If you remember, plasty means to repair or to fix. Vasodilation, widening of blood vessels. Vascular disease, right? For vascular, that's just any disease that affects blood vessels. So just remember these: angio, vaso or vaso, vasculo, just mean vessel. Again, not really specific to an artery or a vein, just the term vessel in general. All right, the next term is phlebo, or veno, and both of these mean vein. And a vein is what carries blood back to the heart. So a good way to remember phlebo is to think of a phlebotomist, right? Someone who draws blood from a vein. You could technically call it a venologist if you wanted to. Maybe it was called venologist at one time. or a venologist, yeah, technician. Um, some good words with phleb and ven are phlebitis, that just means inflammation of a vein. And then for veno, we could say venous, not venomous, right? Don't get confused with that. Venous, which is return of blood flow back to the heart. So phlebo and veno, they always mean vein, not artery, which is the next term, arterio. Now that means artery. One way to make sure you don't get this confused with something else like angio, right? Arterio, angio, because they both start with an A. We're dealing with the cardiac system. Arteries are what carry oxygenated blood away from the heart. Remember, angio is just dealing with the generic term for a blood vessel. Right? So arteriosclerosis is our example term, and that just means hardening of the arteries. Arteriogram is another example, and that's just an x-ray of an artery, or if it's broken down, it's an image of the artery. Right? So be careful not to mix up words like angio, which just means vessel, and arterio, which is specific to an artery, a blood vessel. This is where some students actually slip up. And one final advice to keep these straightforward while you're listening, just practice them. I'll say take your time, read the material, read it in context, and sometimes if you forget, that'll actually help you sort things out. And continuing, sorry if I raised my voice here at the beginning. I listened to the sounds earlier and it sounds like it pops because I raised my voice at the very beginning of the recording. So I try to talk it smoothly and ease into it unless I get one of those fancy filters and stuff on my microphone. So continuing with cardio conversations here, we're going to go ahead and dive into essential cardiology abbreviations that you'll hear frequently both in medical settings and everyday discussions about the heart. So some common ones are AED. This stands for Automated External Defibrillator. I know you've seen these on the walls of actually every state building. They're required now by law. So it's a life-saving device. You'll see them at airports as well, gyms, malls, and other public areas. And what it does is it delivers this electric shock. It helps restore the heart back to its normal rhythm from an arrhythmia. In other words, so if the person has a rhythm for their heart that is not a normal rhythm, right? It actually cannot bring your heart back from no rhythm, what you might actually think in the movies. You'll see that happening in movies with doctors who actually have access to something called a manual defibrillator, where they can actually override and actually just discharge energy into the body. But the AEDs you see in the walls of public buildings, they cannot do that. All right, so the next term is AMI, the next abbreviation, sorry, acute myocardial infarction or a heart attack. This is a medical term for a heart attack, acute myocardial infarction. Sometimes people, they skip the I and they'll just say myocardial infarction. And this happens when you have a coronary artery and it's blocked and it cuts off blood supply to the heart muscle itself, the heart. Right? Next one is ASHD, arterial sclerotic heart disease. This is commonly known as hardening of the arteries, and this is caused by plaque buildup in the arteries, which again leads to reduced blood flow, and it leads to an increase in heart attacks or strokes. The next term, or abbreviation is BP, and that stands for blood pressure. This is an easy one. It's just the measurement of the force that's exerted by blood on the arterial walls. The next one is BPM, or beats per minute, and this refers to your heart rate. I'm sure you're familiar with this. Every time you've gone to a clinic and they've done your vitals, they've checked your blood pressure and your heart rate. And it is just measured by the number of beats per minute that your heart is contracting. Normally, if you're at rest, your heart should be around 60 beats per minute, maybe 100 beats per minute. If you start having elevated, if you're nervous, maybe. But it should be somewhere really low, like at 60 if you're relatively calm. Okay, the last abbreviation here is CABG, often called cabbage. It's pronounced cabbage, like the vegetable no one likes. But CABG stands for coronary artery bypass graft. And surgeons actually pronounce it cabbage. They'll say cabbage. So if you hear the term cabbage around the hospital quite often, they're not referring to the vegetable. They're most likely not. Because it's just spelled that way, CABG, and it can be pronounced as cabbage. But this is what it is. It's a bypass surgery where you get a healthy blood vessel that's grafted, and you use that to bypass a blocked coronary artery. So you get a good blood vessel from some other part of your body, and then you go and you bypass artery in your heart that's actually blocked, and you restore blood flow to that heart tissue. So a good fun fact here, I try to make these things interesting. You might think of coleslaw the next time you hear cabbage, and that's just a rundown of these terms. That wasn't much of a fun fact. Yeah, you might think of vegetables next time you think of the word cabbage, because coleslaw is made from cabbage. That was the whole thing. Okay, let's go ahead and move on to the next section, or next slide. Okay, continuing on with cardio conversations, and I'm thinking I need to give all my lectures some nice title, like cardio conversations, or what was my hematology? I forgot my hematology one. Hematology history. No, it wasn't that. Anyway, today we're talking about cardio conversations, and again, we're just going to continue with this first section, which is dealing with word parts, dealing with abbreviations, suffixes, and prefixes and stuff like that. And we're going to continue with some more abbreviations. And some of these, again, you might know, you might not know. Some of them you should know, I think. I think there's no way you can't know these. The first one on the list, right, makes sense. CPR, I think most people have to know this by now. It stands for cardiopulmonary resuscitation. This is a life-saving technique that's used during cardiac arrest to maintain blood circulation and oxygen flow throughout the body for someone whose heart is not working. And this is the one that involves the chest compressions, rescue breaths, although I don't think we're required to do breaths anymore. I used to teach CPR, and then it changes every so often. But if you can just do chest compressions, and again, this is not CPR advice, I think that is better than no chest compressions. So again, you can do that. It can actually pump the blood through the body that still has oxygen within it and help circulate that oxygenated blood throughout the body. The next one is ECG or EKG, and that just stands for electrocardiograph. And you're wondering, there's two different spellings there, right? ECG and EKG both mean electrocardiogram. Or electrocardiography, depending on how you use it in context. An electrocardiogram is the result of electrocardiography, right? Electrocardiogram is the image, where electrocardiography is the process for obtaining that image. And the image that we're looking at is not like a physical, like a portrait or an image. It's looking at electrical activity of the heart. So we're looking at waves that represent what the heart is doing, right? So why the K though, instead of C, right? Because we say cardio, C-A-R-D-I. K is something that is related to German heritage, right? So it was pronounced EKG with a Kartio, K-A-R-T-I-O, I believe, and that's where that abbreviation came from. But English, it just happens to be the more common language spoken, so we tend to say ECG, even though you will hear EKG spoken in just throughout the world, I guess. It's commonly mixed, but more ECG than not. All right, the next ones are LA and LV. This just refers to when we're talking about cardiovascular, left atrium and left ventricle. These are not Los Angeles and Las Vegas. Ha ha ha. Again, the left atrium, that's the upper left chamber of the heart, and the left ventricle, that's that lower left chamber of the heart. That's the one that's responsible for pumping oxygen-rich blood into the body. And the next abbreviation we have here is MUGA, right? M-U-G-A, Multiple Gated Acquisition Scan. And this is a diagnostic imaging test. It evaluates how well the heart's ventricles contract and how well they pump blood. What this does, it measures what's called ejection fraction. Ejection fraction is just that the amount of blood that's being ejected after each contraction, basically, is what it is. So it's that percentage of blood pumped out each time the heart contracts or each time the heart beats. The next abbreviations are RA and RV, right atrium and right ventricle. My joke is, no, it's not a recreational vehicle, like an RV, recreational vehicle. So RA is right atrium. And remember, right atrium, this receives deoxygenated blood from the body. And then right ventricle pumps deoxygenated blood to the lungs for oxygenation. And our last term here is SVT. This is a particular arrhythmia. It's called supraventricular tachycardia. And we know what tachycardia means. That tells us what's happening, and then supraventricular tells us where it's happening. So what it is a fast abnormal heart rhythm, tachycardia, that originates above the ventricles. And this causes the heart to beat rapidly and inefficiently, and this leads to a patient feeling dizzy. They'll have palpitations, chest discomfort, and we can jump into this more when we get into abnormal heart rhythms a little later on this lecture. All right, thank you for listening, and we'll move on to the next slide. Okay, and that's it for this section. Great job. What we did is we looked at combining forms. You can look at more combining forms in your textbook. You can look at more combining forms online. We just covered the ones that are most common. Remember that these are the building blocks for the rest of the topic in cardiovascular. And so just look at these again until you're very comfortable before you move on. The next section, as always, is going to be anatomy of whatever system we're dealing with. In this case, anatomy of the cardiovascular. And we're going to jump into it. And thank you for continuing with Cardio Conversations. Hello again, and welcome back to Cardio Conversations. We're diving into the anatomy part of our cardiology lecture. If you've taken anatomy and physiology before taking this class, you found cardiology maybe a bit overwhelming. And don't worry, this lecture is going to be simple, like I mentioned in other lectures. And if you've never taken A&P, think of this as a solid foundation to build on. All right, let's go ahead and get started with basic anatomy of the heart. By the way, I'm trying to practice for like if I ever do a podcast and sound like people do on podcasts. I don't know. Or maybe I think that's how narrators sound in podcasts. And then the main person just talks. Let's go ahead and talk about the three layers of the heart. Right? We have the pericardium, the myocardium, and the endocardium. These three layers, you can pretty much break them down by their prefixes and combining forms, and you can even tell what layer they are by these word parts. So the pericardium is the outer layer, right? Peri means around. The pericardium is the protective lining around the outer portion of the heart, and it acts to shield or prevent friction and damage as the heart beats and contracts. Right? Because remember, all these things are squished together and they're rubbing up against each other. The next term or the next layer is myocardium, right? That's the muscle layer. Myo means muscle, and the myocardium is that thick muscular layer responsible for pumping blood. So when we talk about heart function, we're mostly talking about the myocardium because this is a layer that contracts to push blood throughout the body. The third layer is the endocardium, and that's that inner lining. So if you remember, endo means inside. The endocardium is the innermost layer. It's the lining inside of the heart chambers, the valves. And again, this helps prevent blood from sticking to the heart walls, and it ensures a smooth circulation. And that's it for this slide. I do have these blocks now to kind of break everything down. I just want you to look at this from a simplistic point of view. Don't be too stressed about heart anatomy. We're not going to dive into it like an A&P class. I think it's pretty easy to remember these 3 layers and their functions is broken down by their names. And that's all for cardio conversations on this basic anatomy. Let's go ahead and move on to the next slide. All right, welcome, and thank you for staying tuned in to Cardio Conversations. Right, we're going to go ahead and keep this simple as we break down the basic anatomy of the heart. And again, we're going to focus on now the chambers, the septum, and the valves. So just a quick note, the heart isn't perfectly vertical like a tic-tac-toe grid, which you kind of see there on the slide. It's slightly tilted inside the chest. And again, the textbooks have great illustration that shows this in more detail. Hopefully in the future, maybe I will put a better image of the heart here. But I just wanted to break up the quadrants, right, and keep this very, very simple so you can kind of visualize the heart, how it's structured like in this rectangular format, and how blood flows through it. So let's go ahead and get started. The septum, right? The septum is the heart's divider. Septo means divider, right? Septum, that's exactly what it is. It separates the right and left sides of the heart. Just like we mentioned before, nasal septum, right? Divides the nose into 2 halves. The cardiac septum, making sure I'm pronouncing that or enunciating that correctly, ensures that oxygen-rich and oxygen-poor blood stay separate. So think of it as that straight line, our diagram here, the straight line down the middle. The chambers of the heart, so the heart has 4 chambers, and a good way or a great way to remember it is that the atria, which are the upper chambers, you can think of A for above, right? The atria are the top 2 chambers of the heart. And what they do is they receive blood from either the body, which is coming through the right atrium, or from the lungs, which are coming from the left atrium, through the left atrium. And so a little bit about plurals, I guess. Atrium is a singular form. Atria is plural. So if I say atria, I'm referring to both of the chambers on top. And atrium, I will be speaking about a singular chamber on top. All right, the next chambers are the 2 at the bottom, the ventricles, right? The lower chambers. And the ventricles, again, the 2 lower chambers, they're responsible for pumping blood out of the heart. So the right ventricle, this sends oxygen, poor blood to the lungs, and gas exchange happens there, right? It gets enriched with oxygen, removes carbon dioxide, comes back into the heart. And then through the left ventricle, that oxygen-rich blood is where it gets sent out to the body. All right. Now the heart valves. One way blood flow is what the heart is, right? Blood should only be going in one direction. If it's not, you tend to have a disorder. And doctors can normally hear that through heart sounds. But the blood flow to the heart is supposed to be a one-way street. And the valves, these are what make sure that blood flows in only one direction. So no backflow allowed. Imagine you're going on a one-way street. You can't go down the wrong way on a one-way street, even if it's just like 2 or 3 feet. And it's like, oh, just right there, and all I gotta do is I'll be going backwards just for a little bit. No, you're not allowed to do that. In the body, if your heart starts doing that, it's a bad sign that you have a leaky valve. So let's talk about these 4 heart valves. We have the tricuspid valve, the mitral valve, which is also called the cuspid valve. Sorry, it's called the bicuspid valve. We have the pulmonary valve and the aortic valve, right? So the tricuspid valve, this is located on the right side, and it's between the right atrium and the right ventricle. And I'm giving you the older terms here. Tricuspid is what it was called. The name changed to right atrioventricular valve. Now see how easy that sounds, because it's on the right side. It's between the atrium and the ventricle. So they decided to rename it atrioventricular, right? And then depending on which side it is which one you call it. Right atrioventricular valve, which is the tricuspid valve. And that happened, I don't know, 2 decades ago at least. Yet we have still not adopted the new term. So you may hear tricuspid valve, and you might hear right atrioventricular valve, and those are synonymous. They're the same. The second valve, the mitral valve or the bicuspid valve, wow, this is getting very confusing. right? And this is why they changed the term to make it something simple. The mitral valve, bicuspid valve, right? That's on the left side, and that's between the left atrium and the left ventricle. So guess what we call that now? The modern term, what we're supposed to call it, is the left atrioventricular valve, right? The left atrioventricular valve is the mitral valve or bicuspid valve. The right atrioventricular valve is what used to be called the tricuspid valve. So now we can call it something and not get confused, because students would find this very, very tricky. We'll get there one day. I think it's been more than 20 years since we should have been moving over to the new terms. Textbooks will still have the old terminology. Okay, the next term is pulmonary valve. This is the same. It controls blood from the right ventricle to the pulmonary artery. So the name in itself tells you where it's at. This sends blood to the lungs. Then we have the aortic valve, right? This controls blood flow from that left ventricle that I mentioned into the aorta. And the aorta is that vessel that delivers oxygenated blood to the entire body. Again, each time the heart contracts, these valves are ensuring that blood only moves in one direction, never backwards. Again, if it does move backward for any reason, that means you have either plaque on the valve and it's not making a good seal, or a weak, connection to the valve, or it's not actually pulling down and making a complete seal. Either way, you need some valve repair. Go to your mechanic, and they'll refer you to a good cardiovascular surgeon. The mechanic will not fix your valve unless it's your car valve. All right. Any thoughts? Anything? Any questions? All right. Y'all never have any questions in these recordings. That's fantastic. I think I like doing these recordings. I want to thank you for continuing on with Cardio Conversations. And on this slide, we're going to continue our deep dive into blood vessels. We're going to go ahead and start off with arteries, which are the powerhouses of circulation. We're also going to talk about capillaries and veins later. But for now, let's focus on what makes arteries so unique and essential to the cardiovascular system. First question is, what do arteries do? So arteries are responsible for carrying oxygen-rich blood away from the heart to the body's organs. And an easy way to remember this, we mentioned before, think of the word A for artery, for away. Maybe that helps. If it doesn't, don't use it. But if it does, then use it. Right? So arteries take oxygen blood away from the heart to nourish the body. And key characteristics of the arteries are as follows. One, they carry oxygen-rich blood, right? Arterial system delivers oxygen to tissues, except in one place, the pulmonary arteries. And we should have covered that in the pulmonary system, where oxygen, poor blood, is carried from the heart to the lungs. So, but this, we're not talking about the pulmonary system. The second characteristic for arteries is they have smooth muscle in their walls. So unlike veins, arteries actually contain smooth muscle, and they use this smooth muscle to expand and contract. So those blood vessels are opening and narrowing on purpose to help regulate blood flow. And it's this elasticity within these blood vessels, specifically arterial blood vessels, that helps maintain blood pressure and ensures that continuous circulation. And the third characteristic is that arteries control blood pressure. So when we talk about blood pressure, the one we mostly think of is arterial blood pressure, that arterial function. So you go to that machine at CVS or Walgreens or any of your pharmacies where they have one of those free ones you can use. You put your hand in that cuff and it's measuring that systemic blood pressure. Now the arteries are dilating, which means they're widening, and then they're constricting, which means they're narrowing. And it's doing that to kind of compensate if your blood pressure goes up or goes down, so that it can maintain a very consistent blood flow throughout your body. And then the fourth characteristic is from largest to smallest. The largest artery is called the aorta, and that's what's coming right out of the heart, pumping blood out to the body. And it ends up in something called the arterioles. Remember, O-L-E-S, that suffix means small. These are the tiniest little arteries that actually make contact with the individual cells or target organs that are going to need the blood, the oxygen, need their carbon dioxide removed, and so forth. Right? So largest artery is the aorta, and it branches all the way down into arteries and arterioles. Okay. Thank you very much for listening to this, and we will see you on the next slide. Continuing on with cardio conversations. In this episode, we're wrapping up our discussion on blood vessels by looking at the three main types, which are arteries, capillaries, and veins. We've already discussed arteries, which carry oxygen-rich blood away from the heart. Now, let's explore the capillaries and veins, which play equally important roles in circulation. Cue the music. Well, I don't know. All right, let's talk about capillaries first. All right. And this is the body's gas exchange system. Capillaries, like I said before, they're tiny bridges between arteries and veins, so they're really all connected. This is the area of the blood vessel where oxygen and nutrients are delivered to the tissues, and at the same time, waste products like the carbon dioxide are picked up from the cells, and those are prepared for removal, all that waste. So capillaries are incredibly small. They say so small that a red blood cell has to pass in a single file. So it's like one red blood cell in a single file and one right behind it. That's how small they are, cell by cell. So what else? Yeah, they drop off nutrients, and like a delivery truck dropping off stuff, or maybe like an Uber dropping off nutrients and food. And throughout the same system, it picks up waste before heading back to transport, so like your garbage truck. The veins, let's talk about veins. These are the blood's return trip. So imagine you're at your house and you go on one highway to go out to something, and then you take the other side of the highway to come back, right? So that's not exactly a great analogy for veins and arteries, but if you only lived at your house, one highway would always take you away, and one would always take you back, and you never go anywhere else. But that's it. Veins are used to return blood back to the heart. So once blood's delivered all its oxygen to the cells, its next trip is to come right back to the heart through the veins. And a good key difference to know between arteries and veins is that veins carry deoxygenated blood, unlike the arteries, right? Veins return oxygen-depleted blood back to the heart, where it goes to the lungs to get reoxygenated. Again, there's one place where this is opposite, and that's the pulmonary circulatory system. So that's a very tiny system, and that's where veins and arteries actually do the reverse for oxygenated blood, but we won't talk about that here. Veins throughout the rest of the body, they don't have smooth muscle like arteries, and so they can't contract and expand like arteries do. What veins do for a mechanism to help blood flow, plus remember venous blood pressure is a lot lower. So in other words, a way for them to prevent backflow is that they use valves. And so at every checkpoint, blood gets pushed through, and if it tries to go back, a valve, it's one-way valve, and it closes so the blood can't go back. So you won't have the weight of the entire blood vessel pushing up against the blood. So you sort of segment it that way. And again, it can only go in one direction. And veins, if we're going to look at veins from like largest to smallest or smallest to largest, right? The smallest vein is a venule, just like in the artery, it was an arteriole, right? The venules are what actually connect to those capillaries. And then it goes all the way up to veins, and veins are those larger vessels that move blood back to the heart. And within the heart itself, just like the heart has an aorta, the heart has a very, very large vein called the vena cava. That's the largest vein in the body, just like the aorta was the largest artery in the body. And so the vena cava is the vein that directs all deoxygenated blood back into the heart. So hopefully I kept this as simple as possible. Again, with the exception of the pulmonary system, arteries send oxygenated blood out, and veins bring deoxygenated blood back. Capillaries are the tiniest blood vessels where cells actually have to travel one by one, and this is where nutrient and gas exchange occur across the capillary and the tissue, the target tissue. Let's continue with cardio conversations. In this episode, we're breaking down how circulation works, specifically systemic circulation, which is what most people think of when they talk about blood flow, unlike what I mentioned before, pulmonary circulation, which we will talk about in a different chapter. Or depending on how you listen to these chapters, you might have already heard that pulmonary circulation system. All right. But have you ever heard someone say, "Oh, your circulation isn't great," right? And your hands or feet are cold, right? They'll normally say something like that. And they're usually talking about systemic circulation. And this is controlled by the left side of the heart, right? So that's what pumps blood out to the body. So let's go and talk about and walk our way through the pathway of blood flow and how oxygen gets delivered to the body through this systemic circulation, or the body's oxygen supply. So the first step would be that oxygenated blood enters the left atrium. So after you take a deep breath, your lungs fill with oxygen, and this oxygen-rich blood travels from the lungs into the left atrium through the pulmonary veins. And then the second step would be that the left ventricle pumps blood to the body, right? So from that left atrium, the blood moves into the left ventricle. That left ventricle contracts forcefully. It's a larger ventricle than the right, so it has higher pressure. It ejects oxygenated blood out through that aorta, and then it goes through the entire body, right? So then it goes out through the entire body, and then oxygen exchange occurs where you swap oxygen and CO2 at the individual cell level. So blood flows through those capillaries. Oxygen is delivered to the cells. At the same time, carbon dioxide, which is that waste product which is happening inside the cell through something called cellular respiration, which we will not talk about in this class at all, but that has a waste product. It is CO2, and it's actually picked up by the blood for removal. Right? Then it takes that return trip. Deoxygenated blood actually goes back to the heart. Right? So it goes back to the heart. It ends up going through what's called the vena cava. That returns to the right atrium, that first chamber of the heart. We call it the first chamber because we're the first chamber that deoxygenated blood comes back to. Right? The blood's given up all its oxygen. It returns to that right side of the heart through the vena cava. We have a superior vena cava and an inferior vena cava. Right? So blood's coming from the top of the heart and the bottom of the heart. Right, superior vena cava is bringing blood from the head and the upper body, and the inferior vena cava, that's returning blood to the heart from the lower part of the body. Right, and it goes into that right atrium, and once it goes into the right atrium, it prepares blood for the lungs. So the right atrium receives that deoxygenated blood, sends it to the right ventricle. From there, it gets pumped into the lungs. Again, within the lungs, it releases the CO2. It picks up fresh oxygen, and we end up here where we started off at the very beginning at step 1. All right. Thank you very much for listening to Cardio Conversations on systemic circulation, the body's oxygen supply. If you have any questions, please ask now. If not, I'll continue with the next slide. Welcome to Cardio Conversations as we continue diving into the coronary circulation, which is actually a subcategory of systemic circulation. That's right. The heart itself is an organ, and just like every organ in the body, it needs its own blood supply to function properly. That's where coronary circulation comes in. So what is coronary circulation, you ask? Even though the heart pumps blood to the entire body, it still needs its own supply of oxygen and nutrients. Remember, that heart muscle, that heart tissue, needs minerals, needs nutrients. It needs oxygen as well to function just like every other cell in the body. So we have these coronary arteries, and they deliver oxygen-rich blood directly to the heart muscle. So we have 4 primary coronary arteries, and hopefully I captured a picture here that shows them all well. Right, so the 4 major coronary arteries, again, I'm not going to make you draw a diagram or anything like that, but I do want you to be familiar with these because we will discuss these when we talk about myocardial infarctions, which is the heart attacks later on. We have the first one, which is the right coronary artery, the RCA, and that supplies blood to the right side of the heart, right? Makes sense? Then we have the left coronary artery, the LMCA, that branches into two key arteries. The first one is what's called the left anterior descending artery. This supplies the front part of the heart. And then we have what's called the circumflex artery, and this wraps around to supply the side and back of the heart. And these arteries, what they're used for is to ensure that the myocardium, that heart muscle, gets oxygen and nutrients, and it needs to keep pumping 24/7 and never gets a break. I was going to say something else until those beeps distracted me. No, that was it. The artery. Oh yeah, what I was going to say is, while I don't expect you to memorize these names, and you're not going to be expected to label these in a medical terminology course, in your A&P course, you will be expected to actually identify and label these terms. So again, think of this course as a nice preview of what to expect for A&P. And you're probably asking, so why is coronary circulation important? Like as if you didn't know, right? So let's talk about what happens when it's not working properly. So like if you have a blocked coronary artery, right, that leads to really, really big problems. So if you have a coronary artery that gets blocked, again, by plaque or clot, I was going to say by a lot of the foods that we love to eat, especially down here in the Southwest, what it ends up doing, it starts cutting off blood flow to a part of the heart muscle. And what ends up happening is that heart muscle is not receiving the nutrients and oxygen that it needs to function. And we end up having something called heart attack or a myocardial infarction, an MI. And so without oxygen, the heart tissue itself starts to die. And this leads to a cascading problem. It leads to more serious problems where you end up with heart failure. And so this is why it's important to understand the coronary circulation as it relates to heart disease and heart attacks. All right, thank you very much, and we'll continue on with the next slide. Welcome back to Cardio Conversations. I'll try to make each slide very very calming and nice to receive. Hopefully that one worked better. All right, so we're here to talk to you about pulmonary circulation, right? The other half of the body's blood flow system. And we already know that the left side of the heart manages systemic circulation, which is sending oxygen-rich blood to the body. We have this right side of the heart that makes sure that the pulmonary system is taken care of. So it takes care of pulmonary circulation, sending blood to the lungs to pick up oxygen. Again, sometimes I have these little ideas, trivia. I was going to compare this to logistics. But I just need to keep going, or else this recording will be hours. So let's go ahead and jump into pulmonary circulation. If you know anything about logistics, you can pause it and sort of think of that analogy and see how it works. But the first thing is oxygen exchange process. So we start off with the right atrium. It receives deoxygenated blood, right? The vena cava, if you remember, that superior and the inferior, they bring back that oxygen for that CO2-rich blood from the body. And then this deoxygenated blood enters the right atrium. From there, it goes to the right ventricle. And the right ventricle pumps blood to the lungs, if you remember that. First, the right atrium sends the blood to the right ventricle. Then it ejects it into the pulmonary arteries. And again, unlike other arteries, the pulmonary arteries, they carry deoxygenated blood into the lungs. Sometimes I say things too quickly. Deoxygenated blood to the lungs, right? And then again, gas exchange occurs in the lungs where carbon dioxide is released into the lungs and oxygen is picked up, right? That oxygenated blood is then sent back to the heart via those pulmonary veins. Then it gets to the left atrium, which receives that oxygenated blood. So remember that the oxygen-rich blood enters the left atrium, is ready to be sent out to the body. It goes through the systemic circulation, and then it pumps all that oxygen-rich blood to the rest of the body, all your tissues, including itself, the coronary arteries. Right? So again, right side of the heart manages pulmonary circulation, left side of the heart manages systemic circulation. And all of this is controlled by an electronic system, and we will talk about that next or soon. All right, welcome back to Cardio Conversations, where we are diving into the heart's electrical system, that built-in conduction pathway that keeps your heart steady and responsive to your body's needs. So, did you know that the heart can generate its own electrical impulses? You did. And oh, some of you didn't. Well, that's right. The myocardium has this unique property. It's called automaticity. And that just means that it doesn't rely on the brain to tell it when to beat. So instead of like regular muscle, it follows this very specific conduction pathway to ensure that the muscles contract, relax in a very coordinated manner. And everything has to happen a certain way for not only these muscles to contract and relax and pump blood, but to pump blood efficiently. So let's jump into the electrical conduction system of the heart. So you might be familiar with normal heartbeats, how they start at the same place, and they start at some place called the SA node. That's an abbreviation for sinoatrial node, and that is referred to as the pacemaker of the heart. Right? It's a clump of cell bodies, neural cell bodies, and they set the pace for how fast the heart can contract. So this sinoatrial node, I'm going to try to pronounce it correctly, it's sometimes just called the sinus node. Not sinus like in your nose, but your heart's sinus. And what it does, again, it sets that pace for your heartbeat, responds to metabolic demands if your heart needs to pump faster. So if you start running, it increases heart rate, and we call that tachycardia. And let's say you're sleeping and it slows things down, we call that bradycardia. Right? We've mentioned those words before, but not in context of anatomy and physiology. The next term is atrioventricular node. Right? So the AV node, this is a relay station, or you can think of it as a relay station. So electrical impulses, they travel from the SA node to the AV node, and that's located in the junction between the atria and the ventricles. That's why it's called the AV node. It holds a signal for a little bit, and then it allows the atria to finish contracting, both atria, before the ventricles actually take over. So there's a little delay there, right? And then it goes down through this bundle of fibers, and it's called bundle of His, right? It's the electrical highway of the heart. And so once it gets to that AV node and it has that little delay, it passes that impulse to this bundle of His, or bundle of nerves, and it acts like a highway for the signal to travel downward to the muscles, to the apex of the heart. And it also, at the same time, branches out. It branches out to these things called bundle branches, which are, think of it like a fork in the road. So these bundle of His, it bifurcates, it splits into right and left branches, or right and left bundle branches is what it's called. And it sends that electrical impulse to both sides of the heart. From there, it ends up in something called the Purkinje fibers, and this is that final spark of the conduction system. The impulses, they'll reach these, what did I say? Purkinje fibers. Did I say Purkinje? I don't know why. My memory just feels like I just said an incorrect word. Purkinje fibers. Yeah, let me say that 2 more times in case I mispronounced it. Purkinje fibers. These spread along the outer walls of both ventricles. So what happens with this, it ensures that you have this strong coordinated contraction of the ventricles. And that strong coordinated contraction helps eject blood out of the heart with a good amount of pressure, right? Because it's contracting from the outside of the wall and the inside of the wall. All right, so let's talk about some terms about understanding contraction. Systole and diastole. You might hear these terms used in the hospital. Yeah, right. So systole and diastole. So systole, it just refers to contraction. Right? So during systole, a lot of stuff is happening. The heart is contracting and it's ejecting blood from the chambers, but there's a lot of electrical activity that's happening that has to be coordinated for systole to occur properly. Then diastole, that just refers to the relaxation. So during diastole, the heart relaxes, and this allows for blood to start filling into those chambers because it's not contracting at the time. So during that relaxation, blood is allowed to fill into the chambers, and what it does, it prepares for the very next beat. A good way to remember it, or there's probably other ways, but if this helps, I hope it helps. Systole, right, starts with an S. Think of it as squeeze, and diastole, think of dilate. So systole, squeeze, that's where blood gets ejected. Diastole, think of dilate, that's when it's relaxing. Hopefully that helps put these terms into memory. And that's it. That was very simple, stress-free, hopefully stress-free of the cardiac system's anatomy and conduction process. So what I gave you was an easy to follow, hopefully not overwhelming essentials of the heart. What we're going to do next is get into health and wellness, and this is where we talk about what happens when things go wrong. So like when you have heart disease, to arrhythmias. Arrhythmias are just anything that's related to that conduction system, to having problems with circulation issues within the heart. Again, if you have any questions, please ask now. Okay, no questions. Thank you very much, and we'll see you on the next section. And welcome to Cardio Conversations. You've made it to this next section where we will be shifting our focus to health and wellness in cardiology. Remember, this is a continuation of what we learned so far, diving into how we assess the cardiovascular system and what happens when things don't work quite as they should. So after this section, or after this lecture, we'll move on to the final portion, which is cardiac procedures. But for now, let's focus on how we evaluate heart health and the common conditions that can impact it. Cue the music. Da, 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 da. And welcome back to Cardio Conversations. Again, we're going to be diving into the cardiac assessment in this section, the essential tools and techniques used to evaluate heart function. Remember that every organ system gets assessed, and the cardiovascular system is no exception. While some conditions like respiratory distress are easy to recognize just by looking at a patient, cardiac assessment requires more detailed evaluation. So let's go over some key components of assessing heart health. First is observation. So before using any medical equipment, the first rule of assessment is observation. Just looking at the patient can give you clues about their cardiovascular health, their love life, and quite a few other things, but we'll focus and stay on the medical aspects of the observations. Right? So some things to note might be skin tone and energy level. Again, while both of these can indicate information about the patient's social life, let's go ahead and focus on the heart health. So skin tone can show us if a patient has poor circulation. Right? That may cause them to be pale, bluish, or they can have what's called mottled skin, M-O-T-T-L-E-D. Right? And their energy level. They may be low in oxygen delivery from the heart, and that can lead to fatigue or weakness. Or they just may be, no, let's just stay on the biological. You can also look at visual cues, and we can get into some detailed methods later for assessment, but let's go ahead and jump into some of our first interactions with the patient, right? So we can listen to the heart sounds, for example. We call this auscultation, and you can maybe do it with your ear, but we use a device called a stethoscope, right? So when we say auscultation today, we do mean that we are actually using a medical device called a stethoscope to listen to the heart, but it wasn't always the case. Right? So There are other sounds in the body that a doctor needs to be familiar with, like lung sounds and bowel sounds, but heart sounds require more precision and a lot more experience to assess properly. Right? So a good heart doctor, a cardiovascular doctor, can auscultate, and that can take anywhere from 30 seconds to a full minute if they're proficient at it. And what are they listening for? So they're listening for heart sounds that they designate as S1 and S2, as in Sierra 1 and Sierra 2. So S1, S2, right? Very specific sounds that the heart makes, that should make in a certain way. So they listen to, if you're listening to a healthy heart, they'll hear those two primary sounds. The S1, which is supposed to be the first part of the sound, that's normally associated with a sound that sounds like lub, right? The lub dub, if you heard of this. Lub is the first, sound that you're trying to listen for, and that sound occurs when the heart valves close during systole, that contraction phase. This is also that forceful ejection of blood from the heart. And so that's that first sound they're listening for. The second sound they're listening for, the S2, is referred to as the dub, right? The second sound. And this happens when the valves close just before diastole, that relaxation phase. And so this marks the end of the heartbeat cycle. And this is important. So when we look at both sounds, S1 and S2, the lub-dub sound, lub-dub, 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 that's where it kind of comes from. It's a rhythm that you should hear that's steady and consistent. Right? Robin Williams makes a good joke about this. I wish I had the clip to insert. Maybe I will on a future update of this recording. All right. So it's also good to listen to make sure that this is consistent and make sure you don't hear any abnormal heart sounds. Abnormal heart sounds are what we call murmurs, and these could indicate some potential heart issue. But for now, we're just going to go ahead and focus on the basic healthy sounds, the S1, the S2, the lub-dub. Right? Next is pulse. You can measure heart rate and rhythm of a patient. Right? So your pulse kind of gives you two good pieces of information. It'll tell you how fast your heart is beating, that's your pulse rate, and whether the rhythm is regular or irregular. So a normal heart range is supposed to be around 60 to 100 beats per minute. That's at rest. So you're sitting down, in the exam chair or on the exam table. They are measuring how many beats per minute your heart is contracting, and you should get something around there. If you have anything way higher, maybe you took a serious energy drink and you worked out right before the doctor's office, so you might want to let them know that happened. What also you can determine is if the patient has any unusual stress, right? So maybe they didn't exercise before they went to the doctor, and they say they feel calm, but their heart rate is increased. So this could indicate some kind of stress. So exercise or stress, right? Increasing that heart rate. And then the pulse rate will decrease when a patient is normally asleep or they're in their ideal relaxed state. All right. Next thing they want to do is for the examination is the blood pressure. So measuring that cardiac force, and this is going to be the systemic blood pressure, the ones going out to the body, go to the arteries, not the pulmonary system that we've mentioned throughout this lecture. So when I say blood pressure, it's a cardiac assessment measuring the force of blood against, what it really is measuring is the force of blood against the arterial walls as the heart pumps. So, and we'll talk about some specific blood pressure readings and what they mean later on in this lecture. And so, just to kind of put all this together, observations are the first clues that a doctor can get about looking at your heart health, possibly your social life, right? Bad jokes here. The auscultation is what helps the doctor hear the heart's function. And of course, they auscultate other systems as well, the pulmonary system, the GI system, of course. And then pulse and blood pressure, these indicate the heart's rate in health, right? So they can listen to all this to kind of get a good assessment, initial assessment. And that's going to be it for this slide here on cardio conversations. We're going to go ahead and discuss blood pressure in a little bit more detail in the next slide. All right, welcome back to Cardio Conversations, and here we're going to go ahead and dive deeper into blood pressure, what it means, how it's measured, and the conditions of hypertension and hypotension. Remember that blood pressure is a key indicator of heart health, and understanding how it works can help you recognize when things are normal and when they might be a cause for alarm or concern. Let's go ahead and start breaking these down. You might want to go ahead and start visualizing yourself sitting at a CVS or a Walgreens pharmacy. I actually don't even know if CVS exists anymore, but any pharmacy. And they usually have one of those free blood pressure machines. You could take your blood pressure. Or if you have one with you, you might want to take your blood pressure as we discuss this information. Okay, so blood pressure. We always record this with two numbers. And you'll never hear someone say just a single number. So what we do is we measure systolic over diastolic. Systolic pressure is that top number. Diastolic number, the pressure, that's that bottom number. In an example you might have heard, if you're around healthy people, or you yourself were healthy, would be something like 120 over 80 millimeters of mercury. You might have not heard the millimeters of mercury, you might have just heard the numbers, 120 over 80, or 120 over 70, or something like that. All right, so systolic being that top number, that's the pressure when the heart contracts, ejects blood. And since it represents that forceful movement of blood, it's always the higher number. And diastolic number, like I said, is the bottom number. This is the pressure when the heart is at rest between the beats and it's relaxing. So this is always going to be the lower number. You're never going to have these numbers flipped unless you're hooked up to some medical device for torture. I don't know. And the trick to remember here is that think of blood pressure like a fraction. Systolic is always on top, diastolic is always on the bottom. You can also think of D for diastolic as down, D down number, if that helps. But you'll never hear anyone say 80 over 120 because the convention is systolic over diastolic. Systolic is always higher than diastolic. Right? So let's get into a little bit about understanding blood pressure ranges. Right? So the gold standard for normal blood pressure is about 120 over 80. But blood pressure does fluctuate throughout the body, and when it consistently rises or falls outside of those normal limits, it can indicate some more serious problems. So let's talk about the first one being hypertension, and hypertension just refers to high blood pressure. So this is when you have high blood pressure over some time, not just like an isolated incident. So like you do yoga or something and then you stand on your head and all of a sudden your blood pressure kind of goes up because of that, but as soon as you sit back upright it all goes back down to normal. Like that's not the hypertension we're talking about. It's where you're sitting down, you're relaxed, you're at the doctor's, or you're just at the pharmacy, you're taking your blood pressure, you're very happy and relaxed, but your blood pressure is elevated. That's the hypertension that is a problem. But if you slammed your finger in the car door on your way to the pharmacy and you get a seriously high blood pressure because you're experiencing pain, that's not what we're talking about. Yeah. Let's talk about stages of blood pressure. So when your blood pressure goes from that normal 120 to 80 into something like around 140 over 90, that's what we call stage 2, right? And so once you start getting to this, you start getting into the hypertension range. And this is where doctors will start considering medication to give you medication to lower your blood pressure and hopefully reduce complications, because just the blood pressure alone being raised will cause more wear and tear on the interior of your body and things that are pressure regulated, like your kidney filtration, kidney which filters the blood. Right? You want that to be at a consistent pressure, and it can only tolerate a certain range of pressure. So if you have high blood pressure consistently and you don't address it, It can lead to heart attacks, it can lead to a stroke, and as I mentioned with the kidneys, it can lead to kidney disease as your kidneys start breaking down. It can cause damage to the arteries over time, and they call this a silent killer because people don't feel symptoms until the complications get past this point of no return. I mentioned that your body is really good at homeostasis, meaning it maintains nominal values on most things like your pH, your blood volume, and so forth. And hemostasis is something else that the body is really good at, trying to maintain that certain amount of blood level pressure. And so as your blood pressure starts going up, your body might actually be compensating by maybe dilating your arteries and reducing that pressure so you don't feel it. But the fact is, as that compensation is working to help maintain that nominal blood pressure, you're actually not well, right? Even though you might be reading a normal blood pressure, right? Until you get to the point where your arteries can't compensate for it anymore, and you stretch those to the max, and anything past that is just going to be high blood pressure, and you're past the point of relaxation, and then you need medication and things to kind of help reduce that blood pressure. The next thing we're going to talk about is hypotension. Hypo is the reverse of hypertension. Again, this is when your blood pressure is too low. And the difference from hypertension for hypotension is that there's no real official numerical cutoff for hypotension. It's more about symptoms and numbers. There is a danger low, and I'll talk about that in a minute. But let's talk about first what would be considered low blood pressure. So if you had something like 100 over 60 millimeters of mercury, you're thinking 100 over 60, that's well below 120 over like 70 or 80. That's actually okay. There's a lot of people who are like runners, and these are their normal blood pressures because their body is actually more efficient. So for them, this would be normal. It wouldn't even be considered hypotension. But you can't go too low because one thing I won't talk about here in detail, but I may have mentioned it in the pulmonary section, is that gas exchange that I talked about, the O2 going into the cells and the CO2 coming out of the cells, and then the O2 coming in from the lungs into the capillaries, into the cells, and the CO2 leaving the cells, going through the capillaries into the lungs and releasing. Those are dependent on partial pressures of these gases. And there's a minimum gas pressure that you have to have, a partial pressure of like O2 to CO2 within the cell and outside the cell, and then within the lungs and outside and within the cells, so that gas goes in the right direction. And if you don't have that minimum, this will cause poor gas exchange. So there is a minimum that you can't go below. Right? And what's going to happen is that you're going to start feeling dizzy, blood pressure is going to be dropping at the same time, you'll feel lightheadedness, you'll feel like fainting, you'll feel weak, especially if you stand up right away and you feel like that dizziness when you stand up right away. Yeah. So if a person feels fine with low blood pressure, it's usually no big deal. It could be they're just in good health, right? Or they could be a long distance runner, especially long distance runners have low blood pressure normally because their body's just, I'll just say it's kind of running more efficient. And that's it. Let's go ahead and move on to the next slide. Okay, welcome back to Cardio Conversations, and here we're going to go ahead and dive into myocardial diseases. These are conditions that affect the heart muscle and its ability to function properly. So there's several major conditions that we need to cover in this class, including angina, cardiomyopathy, cardiomegaly, myocardial infarction, or acute myocardial infarction, better known as a heart attack. Right, so let's go ahead and get started. And the first one is angina, and this just means chest pain without heart tissue death. So angina is like chest pain caused by reduced blood flow to the myocardium, but it doesn't necessarily mean that you have heart death or heart tissue death. It's not a heart attack, in other words. Why does this happen? You can have coronary arteries that supply oxygen to the heart muscle, but if they become partially blocked by plaque or deposits or even a blood clot, that's not an embolism yet. What it does is just it results in poor blood flow, reduced blood flow, and then that's what's going to lead to the chest pain, the angina, especially during exertion when the heart needs more oxygen. So if you've ever been out in working on your yard in the middle of summer in Texas, because it's very hot and humid here, and all of a sudden you get this very sharp pain in your chest, you might want to go get that checked out, because it could be that you have plaque or blood clot or something that kept you from exerting yourself. All right, and key things to look out for angina is that it comes with exertion. It improves when you rest. So if you feel it, but then you come back inside the house and you sit down and you notice it just goes away, you might have angina. So if you start noticing something like that, keep track of it, keep a log, or just make sure you make a note of it in your memory to make sure that you are noticing the symptoms, and it could be that you have angina. That way you can tell your doctor more specifically what they need to be looking at. So again, angina is not a heart attack. You don't have permanent damage to the heart, but this is like a precursor or a preview that something more serious is coming. All right, if you don't change right away. The next one is cardiomyopathy, and this is just a general term that means disease of the muscle, heart muscle actually. And so if you break it down, right, cardio means heart, myo means muscle, pathy means disease, and this just refers to any disease that affects the heart muscle that reduces the heart's ability to pump effectively. There's different types of cardiomyopathy, and we'll cover those in future slides, but here just want you to get to know the general term. Cardiomegaly, right? Megaly, right? You know that means enlargement, and cardio means heart, so this is an enlarged heart. And it is not always a good thing, because it might not enlarge proportionately the way you think it is. It might enlarge in a way where there's less space inside the ventricles, and there's less ejection fraction, so less blood being pumped out to the body. But I can understand how there could be some confusion. You think, oh, this person has a big heart, and it's like, oh, it's kind of like, sounds like a good thing, but or more power, right? Someone has a big heart, it's like, oh, maybe this person can endure more, push more. If it's growing from the inside, and those chambers, instead of being nice, big ventricles, the ventricle space within inside that pushes the blood gets tinier and tinier because the muscles are getting thicker and thicker. Yeah, it's going to be less blood that you pump per contraction. Right? So the muscle itself gets too large, and that's just bad, and it becomes inefficient, really. And there's other ways that it can enlarge, where it enlarges from the outside, and the integrity of the muscle wall itself becomes weak, where it can't contract properly and push blood out with the right amount of force. Right? So these are things to take away. So a bigger heart is not necessarily a stronger heart. Doesn't mean that it isn't. I just saw a case where someone was kind of baffled to doctors. He was large. He's 7 foot something, but he experienced none of the negative symptoms of people who have like gigantism or something like that. He just happens to be a very large proportioned guy, and his heart is fine, everything is fine. So in that case, that particular individual, just being a larger person, also has a large heart to compensate for the larger body mass. So not necessarily a bad thing when you say cardiomegaly or an enlarged heart, but I think most likely it is more often than not. So myocardial infarction, MI, right, or acute myocardial infarction, that means heart attack. We've mentioned this several times. This happens when those coronary arteries that are supposed to supply blood to the heart tissue itself, they get cut off for whatever reason, a clot or there's plaque, it gets completely blocked. And so what happens when the heart tissue doesn't get blood? Well, it dies. The heart attack itself, because it's dying, it's not contracting properly, it's not pushing blood throughout the entire body properly, and so because of that, it's also not feeding itself properly, right? So it leads to a cascade effect of problems within the tissue, right? What can cause myocardial infarction is plaque buildup like atherosclerosis, or you can have a clot, a blood clot like a thrombosis that blocks an artery. And it depends on how severe it is based on where the blockage occurs. So if the blockage is in one of those 4 major arteries that we mentioned, the damage is pretty severe and it can be fatal. But if the blockage is in one of the smaller, less tissue affected arteries further down, it's not likely to be fatal, but still very painful, and then can progress into something worse. So doctors, you can look online, look for surgeries where they'll show you the entire surgery and how they unblock the artery, the coronary artery. All right, and that does it for this slide. This is a very long slide. Let's go ahead and move on to our next slide. And continuing with cardio conversations, we're going to talk about myocardial disease, or continue with myocardial disease. And now we're going to look and focus on long-term consequences of heart damage. And we're going to talk about congestive heart failure, some valve disorders, and infections of the heart. So if you remember from the last slide, we talked about myocardial infarction, a heart attack. Now again, that leads to permanent tissue death. And what happens next is what we're going to talk about here. So let's go ahead and jump into the first one, which is congestive heart failure, CHF. And this is when you have a weak or overworked heart. The heart failure happens when the heart just can't pump effectively due to that weakened, damaged muscle. And how do we get from myocardial infarction to CHF, to congestive heart failure? I kind of brushed on it in the last slide, but again, when part of the myocardium, that heart muscle, dies, it can't contract or pump blood efficiently, and over time it just weakens and it gets progressively worse. And that's kind of like the big picture there. The right side versus the left side heart failure, you can look at that, where the right side heart failure, let's say from a right side myocardial infarction, this is where you have right ventricle pumps pumping blood to the lungs. That weakens, blood backs up into the body, and then that leads to swelling in the legs, the abdomen, and the liver. And you can have left side heart failure, again, from the left side, or having a left side myocardial infarction. Remember, the left side, left ventricles, they pump blood to the body. So when this weakens, blood backs up into the lungs and causes shortness of breath, and fluid can build up, and you can get what's called pulmonary congestion. Right? So one thing to take away from CHF is not just about the congestion part, like a stuffy nose. It's about fluid overload and poor circulation due to heart failure. All right, the next condition is endocarditis. If you remember, endo just means inside, itis means inflammation, cardi obviously refers to the heart. So this is an infection of the inner heart lining, right? The endocarditis. It actually means inflammation of the heart, but inflammation is caused by an infection in this case. So endocarditis is the infection of the heart's inner lining, because it's endo. Again, it's usually caused by bacteria, or often caused by bacteria. And how does this happen? Well, that's a very good question. What happens is bacteria goes into the bloodstream. It can go in through IV drugs use. You can get a dental infection. In fact, dental infection is a little bit more common than you might think. Or just a surgical procedure. You're in there for a procedure and you get it because of something that's already being done to you. What happens is the bacteria, they'll stick to the heart valves. They cause inflammation and they end up causing damage to those valves. Right? There's no Valvoline or nothing you can pour into like your automobile and just have those valves nice and cleaned. And so endocarditis itself is dangerous. What happens is it causes valve damage, it leads to heart failure, it can lead to blood clots, and that can spread an infection anywhere. Yeah. The next thing we're going to talk about is mitral valve prolapse, MVP. Right? This is a failing heart valve, and a mitral valve, again, it's the most common valve that's affected, right? It's the most common valve with problems. Any valve can have these issues, but the mitral valve tends to be the one that has the most issues. and you can have something called a mitral valve prolapse. How do you get it? By it just not sealing properly. I think I might have mentioned a few reasons. If you have a bad valve and the valves are not making that seal properly, instead of keeping blood going in one direction, blood leaks back in the other direction. So you don't have one-way blood flow the way you're supposed to. Blood will leak backward, and just think about that. If blood is leaking backward, it is making the heart less efficient. So you can think of the blood pressure not being proficient to pump blood to the rest of the body. Right, so instead of that normal lub-dub heart sound that I mentioned, lub-dub, 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 you're going to hear some added sounds added to that, some artifacts because of that, of the valve not closing properly. And you're going to get like a whooshing murmur. That's going to be because of the backflow. Right? Lub-dub, lub-dub, and it's just, it can't hold the pressure in one direction, so it leaks right back. Yeah, there are websites where you can actually click on these sounds if you want to hear them. In case my sound effects are not entertaining enough. All right. So how do you treat this? Well, you can do something called valvuloplasty or a valve replacement. Robin Williams, he had valve replacement. I think he mentioned he had the option of valvuloplasty or valve replacement. And he actually had a bovine heart valve, so it was a heart valve from a cow's heart. Right? Yeah, so your heart valve may not be a human heart valve. So yeah, valvuloplasty is one thing you can do, and that's when you repair the valve. But with Robin Williams, he did say he had the valve replacement. I don't know if that was like the only option, or his valve was beyond repair, or maybe that was the easier option. I have no idea, but he had that. All right, and so remember that the heart, again, the blood is just a one-way system. The blood has to go in one way, and if those valves actually fail, you disrupt the blood flow. And again, you disrupt the blood flow, you disrupt everything that goes along with it, the gas exchange, poor oxygenation, so that leads to fatigue, dizziness, heart failure over some long time. All right. What else? What else? If you ever think of your automobile and you're driving and it's backfiring a lot, right? When we had carburetors, that may have been an issue, but when you have leaky valves that are not holding the compression for that for the fuel to combust completely, and the valves are leaking, yeah, you're going to get a lot of this rumbling in the engine. And so similar assessment. Okay, the next one is pericarditis, and this is when you have, again, an infection in the heart's outer layer, right? So peri means around, carditis means the inflammation of the heart, right? And so pericarditis is inflammation of that protective sac around the heart. Remember we said that protective sac is to reduce that friction when the heart is constantly moving, contracting, so it's contracting and contracting. So it's constantly, expanding, relaxing, expanding, relaxing, and it's rubbing up against other visceral organs inside the thoracic cavity. With that sac there, it's like it's a protective sheet that reduces the friction. I think that's what I wanted to say. All right, so pericarditis can be caused by a bacterial infection. You can also have an autoimmune condition that causes pericarditis. It could also be caused by drug use. And then sometimes you can get a bacterial infection in the blood through drug use. I know I said bacterial infection before, but through IV specifically, you can get a bacterial infection. Things to be looking out for is sharp chest pain, and that just worsens when you lie down. So it's feeling bad, you try to lie down to relax. It's not angina, it's getting worse. And so you're like, I don't think I have angina if it's just getting really, really bad as I lay down. And things to look out for endocarditis, pericarditis, and these infections is that they affect different parts of the heart, and they have usually different causes and complications. So just be aware of all that. I want to thank you very much for listening to this very, very long slide, and we'll move on to the next slide. All right, let's go ahead and continue with Cardio Conversations, where we will be tackling conduction system disorders and what happens when the heart's beautifully coordinated electrical system doesn't work quite right. There's a lot of conduction disorders, and honestly, we could spend an entire semester just discussing them. An entire semester just learning how to read an EKG, and then an entire semester learning how each portion of that signal refers to a particular portion of the contraction of the heart, and then we can spend the rest of the time just looking how every abnormal EKG rhythm can relate to some physical lesion or electrical conduction system problem within the heart. It's quite a lot to cover. So we're going to go ahead and jump in with some basics, repeat some of the basic stuff we said. And the first one is bradycardia, which means slow heart rate. Remember, brady means slow, cardia means heart, and a good heart rate is below 60 beats per minute at rest, if you're resting, for a definition of bradycardia, in other words. And this is for someone, again, if you run a lot and you exercise and you've got a very low blood pressure, that isn't the problem. So just having a low low beats per minute is not a problem if you're like this super healthy person. And you can tell someone who's like a long distance run, very slim and lean, and they got low blood pressure and low blood rate. They're like, oh, this person is most likely because they're in very good shape. But you can tell someone who may not be in very good shape, and if their beats are very, very low, it may be cause for alarm. So bradycardia isn't always bad, right? Real fit individuals tend to have very low heart rates and have very low blood pressures, especially if you go to sleep. Right? So bradycardia can be a problem. Let's say your SA node, your sinoatrial node, stops working, and then the AV node takes over, because it can actually take over the SA node if you lose that function of your heart, the atrioventricular node. But the atrioventricular node, it has a limit. It can only fire like around 40 to 60 beats per minute, as where the sinoatrial node can conduct much faster. So if you try to do anything where your body needs higher beats per minute, greater, let's say, than 60, your heart's not going to be able to handle it, because not the tissue itself can't handle it, but your contraction rate won't handle it. Right? So it's like having a no car that can't go very fast. And yeah. Now I want to try to do an example there. All right. Let's talk about tachycardia, which refers to fast heart rate. Tachy means fast, cardia means heartbeat, and then or pertaining to the heart. And so we define tachycardia as anything above 100 beats per minute. Again, this is in circumstances when it shouldn't be. So if you're sitting down and your heart rate is that fast, that shouldn't be, unless you just drank a bunch of caffeine, or unless you just finished a hard workout where your body's still recovering and it's pumping blood very, very fast. So again, this is not always bad. If you find out the person's just been exercising, or if they are under a lot of stress, stress isn't always bad. If you're scared of something, right? These things are normal reactions of your body under these conditions, right? So, but if your heart rate's 110 beats per minute and you're just sitting down watching your favorite show on TV, then we have an issue, right? So tachycardia can be dangerous because it puts a lot of strain on the heart. And what ends up happening is it's inevitable that the heart will wear out and fatigue, and so you'll have heart failure, and then you can end up with an arrhythmia at any time, meaning the conduction system itself will be affected. All right. The next one is dysrhythmia, and hopefully you can make that out by the term. Dysrhythmia just means like bad rhythm, so irregular heart rhythm is what it means. Dys means abnormal, and rhythmia means rhythm. So dysrhythmia is just a very broad term for an irregular heartbeat. So it doesn't follow that lub-dub pattern anymore. When something disrupts that conduction pathway, the rhythm becomes very abnormal. Right. Next, we're going to talk about flutter versus fibrillation. Flutter versus fibrillation. And that's when the heart beats too fast, right? So flutter is when the heart rate's at 200 beats per minute and higher. who had Wolverine in the movie, right? His heart is going up actually that fast, and so is his blood pressure. So you can still have your heart rate still be coordinated, but the problem is that it's way too fast for the heart to fill properly. So when you get like 200 plus beats per minute and you get uncoordinated, you get chaotic contraction, the heart just starts quivering, shaking, instead of beating properly. So imagine that you got a bike pump, right? You're gonna pump air into the bike, and so you want to like lift that handle all the way up and close the handle all the way down, and that's a nice full contraction. But if you're at the very top and you're moving that bike pump like just an inch down, inch up, just going, you know, you're not going to get the same volume of air being pushed into the tire. And so with your heart, you're not going to get the same volume of blood being pumped into the system. So an inefficient heart with fibrillation will cause someone not to be able to recover easily. Okay, the next term, scary for you. Ooh. Ventricular fibrillation, VFib. You'll hear this quite often, VFib. They'll say VFib, VFib. And this happens to be one of the most dangerous rhythms. So if you can think about VFib referring to ventricular fibrillation, you'll see why it's the most dangerous. Ventricles are those larger chambers, right? One pumps blood to the lungs and the other one pumps blood to the body. So those chambers are very important. If you have a problem with those, you're going to have a direct problem with oxygen gas exchange. So, yeah. So ventricular fibrillation is kind of like the same issue I mentioned with the pump. The chambers, the heart isn't relaxing and contracting to its full extent. It's just kind of like shivering. And you grab a bicycle pump and you just start shaking and shivering the little handle. You may get some air into the tire, but it won't be enough. And you'll just, well, in our case, we will, could lead to a myocardial infarction. All right. The next term is called sick sinus syndrome. So when we say sinus, we're talking in the heart, we're referring to the SA node, the sinoatrial node, and the sinus rhythm referring to the rhythm that the sinoatrial node controls within the heart. So when the sinoatrial node stops working or like just fires inconsistently, you're going to have the AV node take over. Now remember, the SA node can handle much higher beats per minute, as where the AV node handles severely less. Right? So the AV node cannot do the job of the SA node. You can lead to bradycardia, which is like heart beating too slow, arrhythmias, which are irregular heartbeats. They don't follow that regular pattern that we saw on the slide. Things you can do for someone with this is they can be implanted with a pacemaker. Yeah, that's it. Just go ahead and stop there and continue on with the next slide. Okay, and welcome back to Cardio Conversations, where we are taking a look at vascular disorders. These are conditions that affect arteries and veins throughout the body, and not just the heart, right? So we're going to talk about aneurysms, arteriosclerosis, coronary artery disease, hypertension, phlebitis, and we're going to end with varicose veins. So let's go ahead and get started. An aneurysm. So this is, first, what is it, right? It's thinning and weakening of the arterial wall, and it can happen anywhere in the body, not just the heart. And some aneurysms, they're actually presented at birth, meaning they're congenital, and others will develop over time. You'll get them over a different time. Right? But an aneurysm overall is just a weak spot in the arterial wall. Think of like a balloon animal. When a clown, they twist the balloon, sometimes very, very thin. They stretch out sections from it, and that's kind of similar to an aneurysm. We have that weakened arterial wall expanding, and it's prone to ruption, just that little part, because it's been extended too far. You might have seen this also on your water hose when it's been left out in the sun too long. It gets damaged, and it's weak, and it can't hold the pressure. So you get this little ball being, generated from like your garden hose. And so that's why this is dangerous. If an aneurysm ruptures, or if a water line ruptures, you can go turn off the valve. But if you get an aneurysm and it ruptures, it causes serious internal bleeding, and then eventually it could lead to death. So yeah, so just think about hypertension, the risks that come with hypertension. Remember, high blood pressure. that puts extra stress on weak arterial walls. It also puts increased pressure on other organs that it depends on. It depends on it. All right. You can treat this with surgery. You can try to repair or reinforce that artery. You can also get bed rest and just look at resting and relaxing. And yeah, so that's what you want to talk about on this slide is arteriosclerosis, which is hardening of the arteries. And let's break this down by word part, right? Arterial means artery, sclerosis means hardening, osis means abnormal condition. Right? So this is common language for something called hardening of the arteries. So what's going to happen is healthy arteries expand, they contract, they regulate blood pressure, and they deliver oxygen. But after some time, this plaque just starts developing in your cell or your blood vessels. The arteries themselves have become too stiff and very less responsive. And so you can lead to something like coronary artery disease, which is again hardening of those heart's arteries. You can have arteriosclerosis, which is specifically affecting the coronary arteries. You can also look at what high blood pressure contributes to other things like micro tears in arterial walls or artery walls. These tiny tears, what happens is that they collect plaque and blood clots, and so they'll start increasing the blockages by their attraction. And this is important for blood pressure because it is kind of dangerous if you don't watch out for it and take care of it. And it damages your arteries. It sets the stage for things like CAD and heart attacks. And that is all I will discuss on this slide, and we'll move on to the next. Okay, thank you very much for making it to this last part of this lecture episode. Yeah, and we're talking about vascular disorders. We covered things like aneurysms, arteriosclerosis, coronary artery disease. We talked about phlebitis, not in the same order. These are should be in alphabetical order. Varicose veins, and then any condition that can seriously impact the heart and human health. So let's dive into some diagnostic tools and treatments that are generally used to manage these conditions. We can look at things like an EKG. We can look at something like an angiogram. And that is it for this section. We will be moving on to the next section, which is procedures. Congratulations, you've made it to the last lecture in our cardiology series. So in this section, we're going to talk about cardiac procedures. And unlike some other specialties, thinking like endocrinology, cardiology has a lot of fascinating procedures to explore. So things like from diagnostic tests like EKGs and stress tests to life-saving interventions like stents or bypass surgeries, pacemakers, you get it. There'll be a lot to talk about. So let's get started. Welcome back to Cardio Conversations, and this is the last lecture being on cardiac procedures, and we're going to start off with some of the most common and essential tests in cardiology. Now, if you've ever wondered about EKGs or ECG, let's go ahead and talk a little bit about it. EKG being the German word, and it's used often in the medical field. Don't confuse that with EEG, by the way, like electroencephalograph, which is looking at an image of the electrical activity of the brain. But an EKG is just looking at the electrical activity of the heart. And so, yeah. So what happens is you'll get a recording of the electrical activity, about a 10-second snapshot of the heart's electrical activity. And so an electrocardiograph machine, right, it looks at the heart's rhythm and electrical impulses. It looks at it from from multiple angles, so multiple perspectives, right? And so that's where you get all those like lead 1, lead 2, lead 3, and all of the other what are called chest leads. And they're basically looking at the heart through a particular path, electrical conduction path. So from that, doctors can look at things and determine whether there's arrhythmia that's present, infarctions, some other conduction abnormalities, because basically that's what the EKG is looking at, the conduction part. But some of those conduction abnormalities could be a result of some physical abnormalities. So you may have a conduction signal that doesn't look right, and that may be caused because you have a something physical wrong with the heart. Right? So it's more than just looking at these squiggly lines. So if you look at the EKG or the ECG, it can tell you tons of information about the heart. Okay, so you see the rhythm there. Let's go ahead and break down the EKG waveform. Right? Each heartbeat produces a specific predictable pattern on an EKG. They tend to look what you see right there on the slide. Right? Starting off with what we see as the P wave, and that actually represents the atrial contraction. So when atria are squeezing blood into the ventricles. You have that QRS complex, that big waveform there in yellow. That represents the ventricular contraction. So this is where you're pumping blood to the lungs and the body. Then we have the T wave. This is what's known as the recovery phase. This is where ventricles reset for the next beat. And why this all matters is because the timing and the shape of these waves, they have to follow that very predictable pattern. So if that pattern deviates even a little bit, it can indicate an arrhythmia. You can have something called a conduction block, or even it can show whether you've had past heart attacks. And so EKGs are normally done during routine checkups. Let's say, or if you come in like you have chest pain, and so they can do that to get an evaluation of the heart, non-invasively, meaning they don't have to like cut or do anything to look at your heart. If the doctor detects any heart palpitations or any skip beats, they can do an EKG. They can even do this before, they will do this like before surgery. They can even monitor your heart over a long time with a small device that you wear called a Holter monitor. You just put it on, it's attached to you and you walk around with it. That's it. So the only problem with like the standard EKG is that no, you could. We're connecting a lot more things with the EKG than we ever have before. Kind of like I said before, you can have an electrical conduction problem, and that'll definitely show up on the EKG itself. But you can also have a lesion or something that's causing a problem with the conduction that interferes with it, and we know what those are as well when we see particular abnormalities on the waveforms, and we say, that is because of some lesion or something on certain parts of the heart. All right, trying to keep that very, very basic. Thank you very much. Okay, continuing on with cardio conversations. So again, we just basically brushed up on what EKGs are, what happens when you get that 10-second snapshot, but that's not usually enough to catch a real heart issue, right? It's just like a photograph. So we do look at the heart and monitor it for longer periods of time. We can do stress tests also with the heart. In other words, we put you under a stressful condition. It's normally when you see somebody like on a treadmill and detect how the heart's behaving during that time. So these are some of the things we can do, but let's cover some key procedures that help sort of detect hidden heart problems that you can't normally detect on an EKG when you're just kind of laying there relaxed in the doctor's office. So there's something called a 12-lead EKG. Right? You can do something called a 3-lead EKG, which is the one with just the 3 wires. A 12-lead EKG is where you have 10 electrodes attached to the body. That's when you get all those wires. And it's called a 12-lead EKG because you're taking a look at the heart from 12 different angles, meaning 12 different directions between those wires. So the doctor will perform this 12 lead EKG. And again, even though doing a 12 lead EKG will only still give you like a 10-second recording, you're looking at it from so many different perspectives, and that does kind of help look at the different parts of the heart, right? But if you have problems with the heart that are intermittent, meaning they just happen every once in a while, and you might not catch it on an EKG again when you're just laying there in the doctor's office, hooked up with all those wires. There may be something that happens to you maybe before you go to bed, or when you initially sit up or stand down or whatever. Sit up and stand down. I meant sit down and sit. Well, yeah, you know what I mean. And so they can attach something to you called a Holter monitor. Holter was it's a brand, but everyone refers to any portable EKG that you carry and wear as a Holter monitor. It's just the brand, the people who made it initially, they call everyone after that same thing. It's like calling every soda after Coca-Cola, you call it a Coke, even though you're drinking like a Sprite. And it's like, I want a Coke. And it's like, okay. But they meant they want a Sprite. They just call everything the same thing. Same thing with Holter monitors. It's just a brand, right? So what happens is it captures every heartbeat over a period of time. So anything like from 12 to 24 hours, you're wearing it and you're just going about your day. And the machine's capturing everything throughout the day. Again, the patient just wears it. It's usually attached to a small little box, and it's about the size of a phone. And then you can just, what the ones in the hospitals, what they look like is it'll look like you're like a little purse. You put this over your shoulder, the little machines inside that little thing, so you're not feeling like a big weight on you. And you're just constantly monitoring your EKG. So my mind was actually going to I was going to say the size of a phone, but we do have those now. EKGs that are probably not medical devices or classified as medical devices, but you can wear, something like one of those watches that you do, smart watches, and that can transmit something to your phone, and you can actually check your EKG, 24 hours a day. But all those things you buy over the counter, they may not be considered medical devices because they may not be as accurate. They might just give you something that's, how do we say, that's just an indication of what your heart may or may not be doing. Right? So they may not be classified as good as medical devices if you buy one of those. I won't mention any brands, but buy one of those smart watches or those little devices that actually can measure your blood EKG. Right? And that's all it does. It just measures your EKG, and it kind of keeps an electrical diary of what's going on. It'll keep track of any fluttering, if you skipped any beats, if you've had chest pain. The machine does it and keeps track of it, so you don't have to. And again, it's also very important because it keeps track of it during your everyday activity. So again, when you're in the doctor's office sitting down, you're probably prepared and relaxed, and you're not stressing yourself out. But when you're at home doing your normal things, it could be something there that's causing it, or something that you're doing, and the doctor needs to be able to see that. Okay. I also mentioned cardiac stress test. This is when you kind of push your heart to some limit. So if a patient, say they have chest pain, but they don't have any signs of having a heart attack, they can do a cardiac exercise test, and that just helps determine how much exertion is needed before that particular symptom appears. And they'll do that in something called a cardiac stress test. How that works is that a patient, they're hooked up to a cardiac monitor, they're placed on a treadmill most likely, or some other machine. I've seen them on like those stair climbers and some other machines like that, but normally a treadmill. And you slowly increase the incline or the speed to get the person to good exertion, to get their heart to work harder, and see if you can detect any of the symptoms or signs that the patient was experiencing. Right? And so you just do that until the patient develops either like chest pain, or they get to whatever target heart rate you need to get them to, see if anything happens. right? And this is helpful because it's good to help diagnose angina. So angina, remember, is that chest pain when you get reduced blood flow, and it's usually caused during exertion or because of exertion. So we should actually be able to help point out angina if the patient is experiencing that. You can also reveal other things that you didn't realize. You can have some hidden coronary artery disease, and that might actually show up during the stress test. You can do pharmacological stress tests, and this is an alternative to the treadmill. So let's say a patient can't walk on a treadmill for whatever reason. You can do this with like older patients, or maybe a patient in a wheelchair, or just anyone who has a mobility issue that they can't actually be on the treadmill test. So you could run them through a pharmacological stress test. So what the doctors do is that they'll perform this pharmacologic stress test, and that stimulates the heart with medication rather than exercise. And what that does is the patient receives like an injection of a particular medication that'll make the heart artificially beat faster, mimicking that exercise, and the doctors will monitor the heart's response without the physical exertion, but just to get the heart to force the heart to conduct faster and see if anything happens. And it provides really good diagnostic information, as like the treadmill test does. Again, just in case the patient can't walk or run. And that's it for this slide. Thank you very much. Very long slide, and we're going to go ahead and jump into the next slide. We are almost done with this entire presentation. Thank you very much. Okay, let's go ahead and continue with cardio conversations, and now we're going to go ahead and be talking about cardiac enzymes and like why enzymes are so important and what are they, right? So cardiac enzymes are like these biochemical markers, and they help doctors diagnose if you've had a heart attack, and they can also assess your heart health. So someone comes to the ER and they say, I think I'm having a heart attack. How do doctors actually know for sure? They can test the blood, and they can test for the presence of certain cardiac enzymes that will be present if you've had, like, say, muscle death or cardiac muscle death. And so those enzymes are very specific proteins that are in the blood when you have that type of tissue death, and they can actually determine whether you're having one, even whether you've had one in the past, right? You come into the doctor, you're feeling okay, you said, I've been having some problems. They check the blood work, and it's like, it looks like you've had a heart attack. You can have these mini ones, and nothing that would make you feel like you have to rush to the hospital, but you could have had like a mini heart attack. All right, so let's go ahead and go through the cardiac enzymes that doctors look for. And the first one is CPK, which is an abbreviation for creatine phosphokinase, right? And pretty important, right? It's very unique to the heart. So CPK is the enzyme that's found within heart muscle cells. In a healthy person, CPK should not be in the bloodstream, right? But if you have that detected, that's a big red flag that you've had some heart muscle death, and that's why you have that enzyme floating around your blood. And it's useful. So if you detect CPK and CPK is really high, it can suggest that you've had a heart attack very recently. Right. The next one is LDH, and that's lactate dehydrogenase. So this is, again, another indicator of tissue damage. So if you have LDH, when that's released, again, when you have tissue damage, that's going to show up on the blood. It's an enzyme. But unlike the CPK, LDH is found in multiple tissues. So it may not necessarily mean that you've had a heart attack or that kind of tissue death, but you had some type of tissue death, right? Yeah. So again, if you have elevated LDH in combination with other things, you can support that you've recently had a myocardial infarction. So again, you go to the doctor or the ER, you may have already had one, not as bad as you thought it was, so you didn't rush to the emergency room that day. But you come in on a Monday, right? You had something happen to you on Saturday or Sunday, and you just like, show up on Monday, and it's like, you may have had a heart attack this weekend. Okay. All right. So, yeah. If we look at a typical example, like a patient going to the ER, right? They'll go in and they're going in because they feel like they have a really bad chest pain. And even sometimes then it might not be an actual heart attack. It could just be bad indigestion. And this happens, right? People have something and they can have just bad indigestion. I don't want to mention any restaurants that give people bad indigestion, but but it tends to cause like this sharp pain. People can't distinguish between the two, and they run in and it's like, oh no, they just had indigestion. Or it could be just angina from something else that's not a heart attack. Right? So checking those cardiac enzymes will help a doctor tell the difference. Okay, so another one is troponin, right? So this is the gold standard for determining whether someone's had an acute myocardial infarction or just an MI, a myocardial infarction, right? It's the most reliable marker for determining whether you've had a heart attack. Again, and this is only released when heart muscle cells, when they die. So troponin, it actually starts to rise about 4 to 6 hours after a myocardial infarction. So if you were experiencing something in the morning and you don't know what it was, but you end up still going to the doctor, they can still find out whether you had a heart attack or not. Right? So in other words, you go, you get an EKG done, they say, everything looks fine, and then they draw the blood, you had troponin in there, it's like, oh, you're fine now, but these elevated troponin levels tell me that you weren't a little while ago. So again, the higher the troponin level it measured, the more severe the heart attack was. Right, so the next one is called CRP, which is C-reactive protein, and this is a measure of inflammation that leads to or increases the risk for heart disease. So CRP is not really a cardiac enzyme, but it's an important marker of just inflammation in general. So it's like something that you would use with other information that you're gathering from a patient. So a patient has chronic inflammation, that'll play a major role in things like arteriosclerosis, which just means like hardening of the arteries. And so doctors will check CRP. And again, the higher the CRP levels, the higher risk of heart disease or even a stroke. Right? And so that's all we have here for the blood tests and enzymes that we discussed. Thank you very much for listening to this section of Cardiac Conversations. I'll see you on the next slide. All right, continuing on with cardio conversations, we're going to talk about some radiology procedures that are used in cardiology and the specific imaging techniques that will allow doctors to see the heart and blood vessels in action. So these procedures, they'll help the doctors diagnose heart disease. They can help the doctors detect blockages. They can look at your heart function without actually having to do anything invasive. And invasive meaning, cutting into the body. So let's go ahead and get started. The first one we have is angiography. And remember that just graphy means it's a process of recording. Angio is like a blood vessel. So this is imaging the blood vessels. So if we look at this in context, angio means vessel, graphy means process of recording. And angiography, again, is maybe a general term, but it's specialized X-ray procedures that are used to visualize the blood vessel. So like a coronary angiography will specifically look at the coronary arteries to detect blockages and narrowing. And they do this because if you don't know something about X-ray, it kind of goes right through soft tissue. So they'll do this by injecting a contrast dye into the bloodstream, and that just makes the blood vessels more visible on an X-ray. So the doctors can actually pinpoint the areas where you might have reduced blood flow and the areas that could lead to something like a heart attack or angina. Right. The next procedure, again, still using radiology, is cardiac catheterization, and this gives a closer look at the heart's arteries. And who tends to need this will be patients who are experiencing chest pain, angina, right, or a patient who's suspected to have a coronary artery disease. And so during this procedure, what they do is they get this very thin, flexible catheter, and it's inserted into a blood vessel, and it's usually in the wrist or the groin, right? And they kind of thread that up to the heart. This also requires an injection of a dye, because remember, we're still looking at soft tissue, and the X-ray will image the coronary arteries and look for narrowed and blocked arteries. So if you have something that's significantly blocked and it's found, the doctors can immediately place a stent to restore the blood flow. All right. There's a video online. I don't have a link to it here, but I'll mention it. I think it's called like 23 minutes or something like that. And it's the time a patient comes in and they go to the ER, they get diagnosed with having a heart attack, a blockage, and from that moment they step into the ER to the time they're in surgery, to the time they're opened up, they're doing the procedure, and they're unblocking the artery. It's like it took a full 23 minutes from the moment they stepped in to the moment it was cleared. That's pretty amazing. So this can be very, very fast, right? So it's important to understand and to be able to like do these procedures like the back of your hand. Yeah, you know what I'm saying. Especially things like cardiac catheterization. Right? It helps prevent heart attacks if you're not currently experiencing one, right? So you can diagnose a potential issue and identify potential issues and treat these things early before you actually end up having a heart attack. And so I would suggest looking at some cardiac catheterization videos, and definitely look for one. I think it's 23 minutes. Look for one and just Google heart attack blockage 23 minutes, whatever, and that's the time it takes in one particular hospital. Okay, not all hospitals like that. That's the time it took one patient to walk into the ER, be diagnosed, be moved to the ER. Doctors already prepped, a machine running, the fluoroscopy machine, taking an X-ray, being able to identify where it's at, and actually unblock the artery, which is amazing. All right, next one is echocardiography. Echocardiography uses sound waves to image the heart. So if you break the word down, echo refers to sound, cardio refers to heart, and graphy is a process of recording. Right? And what is echocardiography? It's a non-invasive, right? Ultrasound is non-invasive test that, again, it uses sound waves to create a real-time image of the heart. And so in this case, now we're talking about more like a picture, not just an electrical waveform. Right? So it'll allow the doctor to see the heart chambers, the valves, the overall function. And if you've ever seen ultrasound images, right? Those black and white kind of grainy images, they're good enough to determine certain things. It might not be able to find a coronary artery blockage, something so small, but they're good to look at big issues. And you can look at things like heart valve problems. You can look at functions of a heart after a heart attack to see how it's functioning through ultrasound. Again, just looking at function. You can even, if you have the right transducer, you can look at congenital heart defects, which are large enough to be seen with the ultrasound. All right, the next procedure we're going to talk about is transesophageal echocardiography, or TEE. Now this gives us a closer, more detailed echo of the heart. Right, so a standard echocardiogram, it doesn't provide enough detail, but a transesophageal echocardiography, TEE, that provides a clearer, closer image of the heart. And so you can already think about it if you think of the words transesophageal, so meaning there's a transducer and it's going across the esophagus. So this is where they have a transducer inside the body. Not so much invasively where you're cutting into the body, but maybe running it down the throat or something like that. These also can be through the chest wall as well. So instead of taking images with X-ray or just through the chest wall, from the chest wall all the way into the heart, you can use a small ultrasound probe. It's inserted down the throat, down to the esophagus, and bring the transducer much, much closer to the heart. and then you can use much higher frequencies while you're down there to get much higher resolution of the image of the heart, right? Because you're right next to it. And what happens is you reduce interference because you're not worried about the ribs or the lungs anymore. You can just get a much closer image. And who would need a TEE? Patients who have like heart valve disease, blood clots, or infections. Again, you don't have to do any cutting into the patient, like with other procedures. So it's as non-invasive as a standard echocardiograph is, where you don't have to undergo surgery. Right. The next one is a MUGA, right? A multiple gated acquisition scan, or MUGAS sometimes referred to because of the word scan. And what this does is it'll measure heart function over some period of time. So this is another imaging technique that's used in what's called nuclear medicine. So it's a nuclear medicine test, and that measures how well the heart's, specifically they're looking at the heart's ventricle pumps and how well they function. So what happens is they'll put a radioactive tracer, and that's injected into the bloodstream, and you got a special camera that tracks how the tracer moves through the heart. And this is going to give the doctor information and allows them to measure the ejection fraction, how much blood the heart pumps per beat. And you can calculate this, but it's never as accurate as to actually measuring it, right? You can calculate it if you assume everything is normal, but measuring it is the best thing. And it's important for patients with heart failure or some damage after a heart attack, and you want to determine if a patient how their heart's responding to certain medications, and so you'll do one of these scans, right? So that's it for this slide. I want to thank you very much, and we are almost done with this topic. Okay, I want to thank you for making it this far. We are almost done with our cardio conversations. Again, we're looking deep into the cardiac and vascular surgical procedures here and other life-saving interventions that help restore blood flow, repair heart valves, or help regulate like heart rhythms or arrhythmias, what are called heart arrhythmias. So these procedures can range from minimal invasive techniques like PTCA, which we'll talk about first, to major surgeries like CABG, which I mentioned before, which is the valve replacement. So let's go ahead and start with PTCA, which stands for percutaneous transluminal coronary angioplasty. A long word that you'd have to break down every single word and then put all the words together to understand what this is, but I'll go ahead and tell you right now so you'd save you the time. Remember, percutaneous means through the skin, transluminal means across a vessel or some opening, and then coronary angioplasty, we mentioned this, is just reshaping the coronary artery. So putting all that together, you can get a good idea of a definition of what it is. And so what happens is you'll undergo a cardiac catheterization. Right? And that's when they put this balloon-tipped catheter. It's inserted into a blocked artery, and the balloon will inflate. It'll push plaque against the artery walls, and it tries to reopen the blood vessels. I'm trying to think if there's anything in plumbing that could I can use as an example here. But you don't definitely want to do this in plumbing where you put something in the clot and you push the clot all around the tubing, right? You normally want to push it straight through and get rid of it completely, which is better, right? So you do this because you want to restore blood flow. If you have some partially blocked coronary arteries, if you got an artery that's 100% blocked, PTCA won't work. Right? So that's when you need the CABG procedure, the bypass procedure. And that's what we're going to talk about next, which is coronary artery bypass graft, also called the CABG procedure. And it's a procedure where you graft a artery from somewhere else, and you bypass you cut it out and you bypass the one that's blocked to restore blood flow to that particular tissue. So think of it like kind of like a highway detour, right? So you have a major accident, this blockage. And then there's an alternate path if you look at those detour signs, like to go through to get back on track. That way flow can continue moving. And so that's kind of what CABG is. It just reroutes blood around the blockage and ensures that the heart gets the oxygen and everything that it needs. And why is CABG important? Because it prevents heart attacks in patients with severe coronary arterial disease. And it's usually the last resort when they try to do angioplasty, but it doesn't work, or they can't do angioplasty. Right? All right, the next thing is a carotid endarterectomy. So if you remember carotid, those are the arteries that go on the side of each neck, right, to the brain, the carotid arteries. And this procedure is done to prevent a stroke. So what happens is the carotid arteries, they supply blood to the brain, but even those large arteries can build up plaque. And eventually, if that plaque breaks loose, it can actually get stuck in the brain somewhere in a smaller vessel and create a stroke. So what happens, the surgeon removes that plaque deposit from the carotid artery, thereby reducing the stroke risk and ensuring smooth blood flow to the brain. So who would actually need this? Patients, again, with significant carotid artery blockages, especially if they had like transient ischemic attacks, right? Mini strokes. There's tons of videos online that you can find of actual surgeries that have been recorded and full blockages that you can find online if you want to look at those. Kind of amazing, where the plaque is so, it's clogged the carotid so much, and it's about the size of a cork for a wine, cork bottle, cork for a wine bottle. Yeah, it's like a big chunk of plaque. All right, the next thing we're talking about is a pacemaker insertion, and pacemakers are just inserted to regulate the heartbeat. And the kind of people who would need a pacemaker are patients who are known to have an SA node failure, so that sinus rhythm is not normal, and they call this sick sinus syndrome. So they don't have a good sinus rhythm, right? They may have it most of the time or some of the time, but for whatever reason they don't have it all the time. So they'll get implanted with a pacemaker, and this is for people also with like severe bradycardia who have very, very slow heart rates. And so how this works is that you get a small device, it's implanted under the skin. The wires, the leads, they're actually placed on the heart, and this machine will send electrical signals and it regulates the heartbeat. And this is pretty life-saving. So pacemakers take over when the heart's electrical system fails, and it just makes sure that you have a good rhythm. It's just keeping everything synchronized. All right, the next step, next procedure is valvuloplasty. We mentioned this being repairing a heart valve. And so let's break this down. The word, right, valvulo means valve, and plasty means surgical reshaping. And people may need valvuloplasty if they've had problems like mitral valve prolapse, or their valve has been prolapsed, or they can get a valve replacement. So I think Robin Williams, he did have a valve replacement, but I think his was beyond a repair. So he could not have valvuloplasty. Or if he did, it didn't work well, and so he had to get valve replacement. Again, in future recordings, you might just have little clips of Robin Williams' skit when he talks about his surgery. And so valvuloplasty, this is where the surgeon will try to repair that faulty valve so that it does close properly. And what that'll do is prevent blood from flowing in the wrong direction, because you remember in the heart, blood needs to flow in one direction. If the valve is too damaged, the next thing is the valve replacement. So the damaged valve is removed and then is replaced with an artificial or some biological valve. And again, the biological valve may not be from a human, as were in Robin Williams' case, he had a bovine valve replacement. All right, I want to thank you very much for making it this far, and this might be the end of our lecture for this topic. Next, we're just going to wrap it up. And like I said before, that's it. You did it. You made it through all the cardiology lectures. And if my voice sounds unusually high, there's something wrong with my computer that's making my voice sound higher pitched than what it normally is. So if you're listening to me and you're thinking, is that really him? Yeah, there's something wrong with my home computer that's causing my voice to sound slightly higher, like the speed is sped up or something. It's a different pitch. Anyway, just want you to know that it's not your ears. There's something not right with one of my microphones. But that's it. Thank you very much for sticking through the cardiac lectures. Thank you for putting up with my voice if it has been giving you that slightly higher Mickey Mouse sound. From here on out, you need to work on any exercises, homework, so you can get practice, because you're not going to get better at this unless you practice. It's like any other language. So reach out to me if you have any questions, comments, or concerns. Thank you very much. And that was Cardiology Conversations.